Hello, I'm Alan Weil, Editor-in-Chief of Health Affairs. Thank you for joining us for today's Policy Spotlight with Dr. Nora Volkow. Policy Spotlight is a series of virtual events Health Affairs holds featuring in-depth conversations with health policy leaders. My guests have included CMS Administrator Chiquita Brooks-LaSure, FDA Commissioner Bob Califf, then White House COVID-19 Response Coordinator Ashish Jha, and many others. All of our policy spotlights are recorded and can be found on our website. This event also is being recorded and will be available within a couple of days on our website. If you're watching us live, you should feel free to submit questions using the Q&A tab at the bottom of your screen. I'll do my best to weave them into the conversation. I can't make any promises, but if you keep them brief and make them broadly relevant to our audience, they're more likely to make it into the conversation. I'm really pleased today to have as my guest Dr. Nora Volkow, who's the director of the National Institute on Drug Abuse, or NIDA, at the National Institutes of Health. NIDA, the lead federal agency supporting scientific research on drug use and addiction, advances science on the causes and consequences of drug use and addiction, and applies that knowledge to improve health. NIDA has 5 priority scientific areas: understanding drug use in the brain, developing and testing prevention and treatment strategies, accelerating research on the intersection of HIV and substance use, implementing evidence-based strategies, and translating research to health applications. Dr. Volkow has been the director of NIDA since 2003, and this has really been a transformative period for the Institute. And I do want to note, we're of course a policy journal and we're going to talk about policy, but I would be remiss if I just didn't begin the conversation by noting the scientific advances that Dr. Volkow has made, particularly in our understanding of addiction as a brain disease. It's really fundamentally changed understanding of the condition and how we respond to it. And if nothing else, that is an incredible contribution, but we're also going to talk more broadly about the Institute. Dr. Volkow received her medical degree from the National University of Mexico in Mexico City, is trained in psychiatry, worked in the Department of Energy before coming to the NIH. So let me just begin by noting that anyone reading the headlines, anyone working in healthcare, notes the incredible burden of drug abuse, drug misuse, substance use disorders in this country. And it appears in many ways to be worse here than in other parts of the world. I wonder if you could just start with a little context, give us a sense of what are we dealing with here as a country?
Yeah, no, you're noting it very well. The United States has a problem that is very serious as it relates to drug use and addiction, alongside all of its consequences. Perhaps the most notable number that makes people aware how serious it is the overdose crisis that we've been living over the past 2 decades and that we don't seem to be able to control. And the latest numbers that I have actually for 2022 indicate that that year there were more than 108,000 people dying from overdoses. Now, this doesn't take into consideration people that may have died from other causes of drug use, just those that die from overdoses. And it doesn't take into consideration the devastating consequences that addiction has, not just to the person, to their health in general, but to their families and to the system and their communities. Now, notable in parallel, and it's not something per se that we tackle, but that drug use and that need for the drugs also promotes illicit activities that devastate communities and our country. So the challenges are major. Now, I'm addressing it from the perspective of the overdose crisis, but in parallel, we have also a rise in use of other substances, particularly among the adult population, and that is cocaine and methamphetamine have been going up. And at the same time, we've seen a significant rise in the use of cannabis across the country, in part led by policies and that actually have made it legal by the states for medical or recreational purposes. So it is complex. And even though overdoses perhaps may be one of the most tragic ways that we can communicate the devastation, it does not end up there.
Well, That's so true. And I appreciate that although we focus on the horrifying number of deaths, the consequences are broad, much broader than that. I did note in the substances you mentioned, you didn't discuss alcohol. And I wonder, we read about the concept of deaths of despair, this notion that sort of all of these are manifestations of the same ennui and disenchantment, disillusionment with life and the world, and that they can come out in manifest in very different ways, but have a similar root. I wonder if you could just give me a sense here. Do you think of these as independent problems or interrelated problems, or the same problem? How does a scholar of this topic approach the question?
I'm glad you're putting me to task for not mentioning alcohol. And the only reason why I didn't mention it is because there is an alcohol institute. So I'm always sensitive to the notion that from the perspective of NIH, they are two different institutes, one of alcohol and the other one, the rest of drugs. But addiction is addiction. And whether it is to alcohol or to fentanyl or to nicotine, this is addiction. And the process at the level of our brain and its disruptions share many, many commonalities. And in fact, we know from genetic studies that the genetics that actually accounts for the most variability in terms of your risk is a general risk genetic factor for addiction. And so very much what drugs you end up taking is dependent in many instances on the circumstances. In others, it may actually does reflect the effects of the drug. So say, for example, someone that is very, very anxious may find alcohol particularly rewarding and reinforcing because it decreases their anxiety. Whereas as someone that actually has a very proactive, likes to be stimulated, may find the effects of sedative drugs much less enticing. So there are absolutely differences in preferences of people for drugs and why they seek them out. But one of the main variables determining what may be the risk of a person on exposure is their context. What do they get their hands on? What are the norms that exist? And that explains why, for example, it seems like it goes in waves. Certain periods, certain drugs dominate in the United States, and others in other periods, other drugs. And then we're living it right now with opioids. I mean, opioids were pretty stable at the end of the 20th century, and they actually, overall, the use of heroin, the overdoses from heroin have been for at least a decade or more at 2000s, tap at 2000. And then all of a sudden, the misuse of opioids, initially through prescription opioids, but then through the entry of massive amounts of heroin, and now through the entry of massive amount of synthetic opioids like fentanyl, is making them available and accessible. So yes, there is the basic concept of addiction, and that is equivalent. And in many instances, again, there are examples where people may have a predisposition for one versus the other, but the main bulk is a general addiction process. Why are we here? And I think that whole concept in terms of why may someone end up having an alcohol use disorder, or someone else up an opioid use disorder, and why are these so prevalent right now in the United States? And it's a very key question, because if we don't understand what is making our country vulnerable to these drugs, then we cannot generate policies that can tackle the issue. And I'm speaking about policies because all of the knowledge of the world, if it's not transformed into a policy that promotes, whether it's a therapeutic or a prevention or a structural change that protect people, then they're very unlikely to solve the problem. So in the case of the United States, it's clear that one of the components that actually leads a person to be more vulnerable is social determinants of health. And if you look at it in terms of our society, there are certain groups that have a much higher burden from social determinants of health than others. So there is a structure in our social structure, the way that is generating these inequities, making some people more vulnerable than others. And that entails for addictions, but as you know, that the term on the deaths of despair, which also goes into that essence about what is making people so despair that they either take drugs to escape, or including alcohol, or they commit suicide, or they basically too, engage on behaviors that are very, very harmful, like morbid obesity, and that in turn negatively impacts their health. So these are social factors that are making people vulnerable at this period in time, and that we need to tackle.
So I appreciate you so quickly in the conversation, sort of building this ecosystem of vulnerability and context that you're in. You describe sort of the availability and the social norms, and then also the social determinants that affect how you feel about yourself and your opportunities for life, and the need to look at all of those together. Of course, the healthcare system in many different dimensions is paying new attention to social determinants and trying to figure out how to provide people with better food access and more stable housing and the like. And we could spend all of our time on that. That's probably not central to what you do every day at NIDA, but I think it is interesting to see that dimension come in so quickly into the conversation. I wonder if we could spend a little time talking about sort of the other side of the ecosystem, which is the diagnosis and treatment side. So once people have a disorder, we have to identify it, and we know that there's very high rates of failure to identify. We know there's a lot of stigma about getting treatment, and then we also know that there are huge barriers to getting treatment even when you want it. And I wonder if we could just talk a little bit about sort of how to, once we have identified someone who would benefit from services, how do we improve our ability to get them the services that they need? So, for example, your institute did a challenge around primary care. Maybe you can tell us a little bit. Primary care potentially is the first line of identification and treatment. So what could we do better with primary care?
I think we can do a lot of things better with primary care. And at the essence, one of the aspects that, again, looking at it from the perspective of solving a problem long-term, is how do we address the issue of prevention and treatment of substance use disorders in our country? And we have a very, very solid system, which are the healthcare system. Even in rural areas, you can access it. Certainly there may be more difficulties in one place or the other, but it's very, very solid. But it hasn't been engaged in the screening or treatment of individuals with substance use disorder. Now, at the essence, are there many factors that why this hasn't happened, including stigma, including actually the stigma that I should say that relates to not just the person that's taking drugs, but the disease as a whole, addiction. The disease of addiction is not considered at the same level as other diseases like Alzheimer's or cancer, because there is always that moralistic message that this is something that the persons are doing to themselves. So why I am bringing this up, I'm bringing it up because as a result of that, reimbursement for services that relate to the screening and the therapy of individuals with substance use disorder is much lower than reimbursement of services for other medical conditions, even though they may require the same or even more amount of time in the case of substance use disorder to take care of the patients. So this is not incentivized. And so clinicians are not willing to jump in the wagon and says, yes, I'm going to start to work with these patients to help them. Because of that, the same background does not incentivize the medical schools or other health schools for healthcare professionals to teach them on how to treat substance use disorder, because there's really the reimbursement model may not justify the incentives to do it. So there are elements to that. So you can look at it. And my brain always looks at alternatives because they say, okay, how do we address that? How do we provide evidence that these incentives need to be improved to involve the healthcare system in a much more active way. But at the same time, the second strategy is what are models of care that we can develop that would make it much more likely for them. It has to be effective, but sustainable, so that it is not so very costly that it becomes prohibitive. So that is where the challenge came around. And so I say, okay, we have the primary care physicians, which is a first line of defense through which we actually monitor our health. That should include actually screening and treating for substance use disorder, but it doesn't. So what models will allow for primary care physicians to be able to get involved in the screening and treatment? So what we do, I mean, we are an agency that funds research, and we have the opportunity of taking advantage of very diverse perspectives that clinicians, scientists, or people who have living experiences or family members have had on what works or not, and just do a challenge and says, well, we want to hear what the proposals you have for primary care to be involved in screening, treating, and sustaining the person into recovery. And so we put money into the table, we put in a competition, and the people that are chosen that then are given the support for 1 year to facilitate their transitioning their model into a product that then can be translated into something that can be developed into the market. So that's the way we work that particular challenge.
So that's that you said primary care physician, and that's important, but there are a lot of primary care clinicians who are not physicians. And one of my questions, and actually, as I started to ask the question, someone from the audience had the exact same one, which is part of the clinician shortage can be addressed by not relying exclusively on physicians. So are there opportunities to broaden our sense of who could provide the screening and the treatment as well?
Thanks for pointing me up on that. It was an omission, so absolutely correct. And I'm glad that person in the audience brought it up. No, we cannot just be relying on physicians to do these interventions. There's no reason why someone else cannot actually properly trained do as good or even sometimes better job. So these many of these models, in fact, relate to involve nurses, physician assistants, and they're also developing training for coaches of people that, because they have lived experience, can participate in the process as liaison to help and provide support. And this is, again, where the models can generate a system that is much more effective and sort of also streamline the expertise of different people to maximize the likelihood that, again, that's why I always bring up the issue that these models will be sustainable because they are not extremely costly.
Well, I'm glad you brought that up, because one of the things that's occurred partly as a consequence of the underfunding, the poor prestige associated with providing these services is this proliferation of peer group and lay-led and sorry, I'm blanking on the right word here. They don't have the imprimatur of a certification or a licensure, and people turn to those in part because they don't have access to more traditional and reimbursed services. So is there a role in research? Again, as you, of course, remind us, you're a research funder. Is there a role for research in helping us figure out how to balance the benefits of the peer and the lay participation in these, but also make sure it's evidence-based and has the continuity and they're actually effective?
Indeed, and we have several projects doing this and working in partnerships with people that are peer coaches and as part of a team, for example, in primary care practices or in IRQs facilities to actually document what are the active ingredients that can make those collaboration effective. But I do want to point out something that always disturbs me enormously, which is the issue of what is the quality of care that people get. And you are bringing it up in terms of there are individuals that may act as liaisons, but they may not have the proper training. And that is correct. And it is our responsibility to provide training such that there is a clear-cut evidence that with that background, they can properly help the person. But that's not just limited to, again, people with lived experiences. It is very relevant for clinicians. And many of the treatment programs, for example, are not accountable vis-a-vis what their outcomes are. And as such, you see a proliferation of treatments in the United States that offer interventions 1 month or 3 months, for which they are not following evidence-based interventions. And so there is, and this has been one of the areas that we have very much prioritized. How do we build an infrastructure that will make the treatment of substance use disorder accountable for their outcomes, such that the reimbursement should be based on outcomes, not you just actually request and that you open up the doors and you say, I have this program of treatment, and no one is overseeing the quality of your care, which is unheard for the rest of medicine. But this is what happens in the substance abuse field. And as a result of that, people end up paying very, very high fees for treatments at which at the end, they basically are discharged with not even a continuity of care that leads them to obviously relapse. So there are many problems that we have in our treatment of infrastructure in substance use disorder that has allowed those practices, improper practices. So what we are aiming to do is to create a way to, like a report card, right? That you have a program, and these are what evidence-based has shown us works, and how many of these elements are provided by your program. And that will qualify the extent to which they are following practices. And to basically have, just like we do in other healthcare systems, determine what the success was or not. And that is something that we sorely need in our country to improve the quality of treatment for substance use disorders in general.
So I want to move on to some other topics, but I have to follow up on what you just said about outcomes. And isn't part of the challenge we have here that they're both politically and maybe you would say clinically, there's been a real evolution of what the desired outcome is, and particularly whether relapse is failure or relapse is temporary. And we have a lot of experience with sort of performance-based programs that create incentives for what, depending on your metaphor, cherry picking, cream skimming, where you bring people in who don't have a serious condition, so your outcomes look better. Or you terminate people before there's a relapse, so it's not in your data set and you don't get penalized for it. Do we really have a nuanced enough sense of what success is to do true performance-based payment in this area?
I think we have some level that could definitively improve it. And in terms of performance, what we do know is that even though abstinence may be the desired ideal outcome in the long term, addiction is a chronic disease, and as part of the process, relapse is considered part of the disease itself. So the fact that you go to treatment and you relapse does not mean that the treatment failed. It just means that you basically need to actually do an intervention that, again, engages in a more focused way for the period of time until you are stabilized. And in a way, this is the way that we treat cancer, right? I mean, when you have many of the cancers, that they become chronic conditions and that you're going to be evaluated and monitored. And if the cancer you relapse, it doesn't necessarily mean that the treatment you provided was the wrong one. It just is the part of the biological process by which these diseases work. And in that respect, it's not different from addiction. There is a chronicity element to it that is the extent to which it manifests is going to, of course, to be dependent of what your circumstances are. So say, for example, you're someone that has gone to treatment, you go home and you have your spouse and your work and everything looks very good. The likelihood that you'll succeed is much greater than if you basically come and your spouse has left you, you have no job, and on top of that, you find yourself in a very stressful economical situation. Your likelihood of success and relapsing is much greater. It is, and 2 days ago, I got an email that made a big impact in my brain, and it was from a person that had been struggled with addiction. And what she was saying, she was on buprenorphine, and she was commenting about how hard it has been, and even though she struggles very much with craving and she's continued to struggle to try to achieve recovery. She says, I don't doubt that people can achieve recovery if their lives are stable and they have all of the support. The ones that fail are us that don't have the structure that makes it easier. So understanding, and that's why I come back again to the social structural systems that we have. They are not just relevant in terms of who is at risk for a substance use disorder, but they're also extraordinarily relevant in terms of who will be more successful if they initiate treatment and who will be more successful in achieving recovery. The odds are not the same for everyone.
You just mentioned buprenorphine. We've published quite a few papers at Health Affairs about medication-assisted treatment and barriers to it. One of the big changes, of course, during the pandemic was this big shift to telemedicine and telehealth. What can you tell us about sort of the constellation of issues around who can prescribe, who can oversee, concerns about misuse and misdirection of medication, and then overlay it with the use of telemedicine?
Yeah, no, and COVID brought some changes that actually have facilitated the initiation of treatment and retention in treatment of people because some of the treatment requirements were very complex. And so we're not going to speak about methadone, which is probably one of the most challenging because the patients still have to go to a methadone clinic. But in the case of buprenorphine, something quite dramatic happened last year, which you sort of in the past, it was required that if you were a physician and you wanted to prescribe buprenorphine, you have to go through a waiver training. And as a result of that, that limited the number of clinicians that were willing to actually go through the training and treat people with buprenorphine. So that was an issue. And also there was a requirement that if you want to initiate someone on buprenorphine, that patient had to go physically be evaluated by the physician. And you may imagine that if you're in a rural area, that will become very, very difficult. So with the COVID pandemic, all of those requirements were basically brought down. So you could actually get initiated in buprenorphine without seeing a person in person. You could actually do it through telemedicine or even through a cell phone. And it could be a physician that is from another state. And as I said, last year, they removed the waiver requirement. So all of those obstacles actually have made it easier for patients to be initiated on buprenorphine. And those that were on buprenorphine, what they've shown is telemedicine has helped them retain in treatment. So we still have major challenges as it comes to buprenorphine and methadone on retaining patients in treatment. So you start them, and we're still losing between 40 and 50% of people to treatment within 6 months. They stop taking their medications. And that, of course, is very, very frequently associated with relapse, and it's a period of extremely high risk for overdoses.
Let me ask one more about sort of treatment, and then I want to move into a different dimension. a whole proliferation of, digital therapeutics, apps and the like. What's your take on the evidence base around any of those kinds of modalities?
Well, we're doing research to try to determine the extent to which digital therapeutics can, for example, improve adherence for treatment of patients with an opioid use disorder. We're also evaluating them for interventions that relate, for example, for young people, for managing other types of addiction. And overall, what happens is that digital therapeutics appear to work well over the first few months, but then people stop using them. So a challenge is it possible, and in principle, theoretically, I think that many things are possible, so it should be feasible, to actually improve that retention so that people stay on using the digital therapeutic. Because overall, when they are using it, it does seem to significantly to improve outcomes overall and to help patients stay in their medications and follow up with behavioral interventions. But then they stop that digital therapeutic.
I want to turn the conversation to some issues of the populations most burdened by substance use disorders. I don't want to get into a long political discourse here, but I think many people view the political response to the opioid crisis having been tied in part to it having being perceived as a white person's problem, and that drew attention to it and resources to it that were not available when the burden of, say, heroin was more disproportionately people of color. We're now seeing that if you look at the data, the burden of the opioid crisis is disproportionately back on people of color. How does that tie into your research agenda? How does it tie into how we think about addressing the issues here?
No, it ties because it's crucial and fundamental. And I was looking at the latest numbers, and I was saying, well, we have 108,000 people that died on overdoses 2022. And so, but if you look at it in a granular level and see how does the trajectories go for white non-Hispanics versus Black non-Hispanics and American Indian, Alaska Native non-Hispanics, overall, the rate of mortality in the United States is like 35 per 100,000 people. In Black Americans is close to 46, more or less. I don't recall precisely. So it's 50% higher in Black Americans than it is in whites. And then in American Indians, it's basically double that of the whites. So you see, and also in the trajectories, you're seeing in the whites starting to come down, but in Black Americans and in American Indians and Native and Alaskan, it just go way up. So we need to pay attention to it, because if we don't address it, the numbers have just shifted from one group that initially was more vulnerable because of prescription of opioids to now basically it has gone everywhere, and it has usually, like it happens in general, the people that are already more vulnerable become the ones that have the worst burden. So how does it translate into research is understanding ultimately what are unique interventions for those individuals and it's not just when you speak about Black Americans or you speak American Indians that one intervention is going to be valuable for everybody. Not at all, but understanding the dynamics and the policies that may be exacerbating these disparities in terms of overdoses. That is crucial that we understand. And so research is ongoing in those means. And two, what is access? What are the access to the treatment that they have so that can be maximized and utilized for treating them and retaining them in treatment? And third, as important, and you're going to be hearing me repeat because we don't speak about it, but why is it? I mean, how can we protect them? What are the prevention measures that we can do to protect Black Americans and American Indians from these overdoses? And we should, because it's actually, if we don't mount a prevention effort, we're just going to be shifting from one group to the other, from one drug to the other, and the problem is not going to solve by itself.
Let me ask about another vulnerable group, which is pregnant women with substance use disorder. You know, again, we've published on this area, and I'm sure you're aware there are plenty of parts of the country where there are laws, in essence, criminalizing having a substance use disorder if you are pregnant, as some form of child abuse, which then has chilling effect on people seeking out and receiving treatment. What are the best practices in the area of addressing this population?
Well, I mean, this is a point that actually, at the end of the day, like many of the issues that we're discussing, relates to stigma. And certainly people that take drugs are highly stigmatized. But of those people that take drugs, the ones that are most stigmatized of all are women that are pregnant. Because there is that moral imperative. What are they doing to the newborn? And that lack of understanding that this behavior is not a choice. And it is, in a way, a reaction, a response for which there are really not many alternatives for individuals. What we want them is then, how do we treat them? How can we, again, divert that trajectory that they find themselves on that will improve their own well-being, but also will improve the well-being of the newborn and the child as it grows along. And we know, and this is research that has been going on for at least 2 decades, that treatment of women that have addictions, and I'm speaking right now for opioid use disorder, are very effective. And they actually prevent them from taking other drugs that are maybe more harmful. They basically protect them, significantly protect them from overdosing. And the outcomes on those children when they are born, we speak a lot about the neonatal abstinence syndrome or the opioid withdrawal, is much lower and easier to handle than when these women are taking drugs like fentanyl and combining it with other drugs like stimulants. So it works. The issue is, why are women not being treated? And then there is where the stigma goes, as you mentioned. And I was horrified when I started to see how many states in the United States actually require that as a physician, if you see a woman that is pregnant and has a substance use disorder, you have to denounce her to child services. And so there is an oversight, and there are 2 states, I don't recall which ones they are, which is good because I don't want to point fingers, but there are 2 states that actually, if you are a woman and you're pregnant, you end up in jail. And obviously, what the fear is, if I am a woman taking drugs and I am pregnant, guess what? If I'm going to end up in jail, I absolutely don't seek medical help, either for my substance use disorder or for the pregnancy itself. So you are really putting women, you're cornering women. And what we saw in the numbers, that's why I actually, the numbers not just speak to us, they shout at us. There has been a tripling in the mortality of pregnant women from overdoses. And this is actually telling us something very compelling, because we have medications that have been shown to prevent, at least by 97%, what other intervention we have in medicine that has that level of protection of overdoses. But we are not, the women are not able to take advantage of it because of all of these stigmatizing practices.
I wonder, as horrifying as that scenario you describe is, my sense, and one of our members of the audience didn't exactly say this, but was talking about who's a provider who's not seeing as much demand as you might imagine, given how many overdoses there are. Even in states without those kinds of laws, presumably the rate of people seeking treatment and obtaining treatment still is far below the numbers who would benefit from it. So I think it's important for us to focus on those two states, even if you don't remember which they are. But I imagine this problem of stigma and failure to seek effective treatment is universal around the country, not just because of those laws.
Absolutely. It's just an extreme, right? I mean, if it is when you are living in a state that has such punitive policies, and you may lose your child, that is a big incentive not to go to treatment.
Right.
In the rest of the country, absolutely, people feel stigmatized, mistreated, discriminated when they actually come up with a substance use disorder. And you hear this again and again and again when you actually speak with people that take drugs and why they don't trust the system. They have been mistreated so badly that they don't want to have anything to do with it. So we do have a problem of trust on the healthcare system or other substance abuse treatment due to the discriminatory practices.
I want to ask about another population, which is youth and adolescents. This seems to be a growing concern. And what differences are there in how we should think about addressing substance use disorder in that population?
Well, in the case of adolescents, I mean, we've known all along, of course, that adolescents can become addicted and they need treatment. And there is limited overall evidence in terms of treatments that are the most effective for adolescents. So there is a need. That is an area that needs many more interventions. We know that buprenorphine has been shown to be effective on randomized clinical trials on teenagers that are 16 or older, but the clinical practice is if you have someone that is 14 years of age that has an opioid use disorder, it is indicated to use buprenorphine. And there's actually also evidence that there may be, again, it's not in a randomized clinical trial, that methadone could be beneficial. And the issue is going to have to be weighted very much on the particular situation of a teenager. We have to realize, and this is in my brain, it hurts me so much when I think about it because it's not a simple answer. We are living in a period, you were asking me how bad is the problem of drug use in our country, and it's bad. But for example, in adolescence, we have relatively very low use of drugs when compared, say, with 20 years ago. And very, very low rates of use of heroin, almost nothing, basically in seeking out fentanyl. And yet, despite that, we're seeing a tripling on overdose mortality from fentanyl in teenagers. Why? Because they do use illicit prescriptions, such as, for example, they may want to take an Vicodin and mix it with alcohol to get high, or a benzodiazepine. What teenagers seek out is benzodiazepines, opioid analgesics, and they actually stimulants like amphetamine, and they use them occasionally. But if they get their hands on an illicitly manufactured one that contains fentanyl, which a significant number of them do, and they contain it at a dose that is sufficient, 30% of them have doses sufficient to kill a person, a single exposure can result in overdose. And that's what hurts my brain, because you say, right now, the drugs that are out there in the illicit markets are extraordinarily dangerous. So in the past, where we would be able to tolerate, no, if this person uses cocaine occasionally here and there are risks to cocaine, absolutely, but the mortality is relatively low. And the same thing, when a teenager uses a benzodiazepine here and there, the mortality was very low. Not anymore. And that is where the issue comes into the issue of treatments, because in the past, your intervention would be much less aggressive. Now that a way I view is I have a teenager or a young person that may have a relatively short history of misusing these substances. And my first jump is, how do I protect that teenager? because a single exposure, and it's not exaggeration, can kill them. So how do you protect them? So the narrative has changed, and how you encourage them engagement in treatment in a way that will really prevent those overdoses that should not be happening. So that's what makes it very, very challenging right now, that the drugs that teenagers or young people can get their hands on are extraordinarily dangerous.
That's so interesting, the way you explain that, and it's the our tolerance for risk now has to be much lower than it was, because the potential negative consequences are profound and devastating. I am curious in this context, and I don't know if you're allowed to answer this question, but I'm going to ask it, and you can tell me whether or not you will. But at the outset, when you were sort of setting the stage, you did refer to cannabis and increased cannabis use in part due to policy changes that facilitate both medical and recreational use. I am curious, given your statement earlier on that sort of addiction is a phenomenon and what you use to satisfy it is very context dependent. Do you see the expanded availability and tolerance of cannabis as a relief valve or a perfectly fine thing in and of itself, or is it what we were all told many years ago watching movies designed to prevent us from doing horrible things, that it is a gateway to things that are much worse? What's your sense?
Well, I think that the answer lies in basically, first of all, it's not a black and white, totally. And we've known all along that, and this is where we lost a lot of the credibility, that there were people that were smoking marijuana and there were no harmful effects to them. And so at the same time, we were saying cannabis is such a dangerous drug. So you start to create dissonances, and our brain can capture dissonances. And that's when I say always my brain hurts. To the question, is certainly there is clear-cut evidence that consumption of cannabis, particularly the one that has high content 9-THC, is associated with very negative effects, like psychosis. Or it can be, I mean, and again, it can, it produces addiction. It can generate what is described as a motivational syndrome, behaviors and consequences that are non-desirable at all. And there's been studies linking it to a higher association with suicides. Now, I'm going to highlight that these are studies that show associations. We have not understood whether they are causally and mechanistically linked, but the epidemiological studies unequivocally show an association with, yes, a higher risk of psychosis, and that is causal. Anyone can become psychotic with sufficiently high THC, but the one on suicidality is less clear. And so there are other consequences. But to your question, it is basically, could you actually use cannabis as a means to buffer that drive and the desire to take a drug, so that you can protect that person from consuming a drug that's much more dangerous? And that falls in my brain in the category of what we do, harm reduction practices. And this has been an argument that the pro-legalizers of cannabis have been bringing it up with respect to management of pain. And with opioids, they say, well, if you do cannabis, then you don't need to use opioids, and then you protect the person from becoming addicted to opioids. So where does the truth lie? Overall, it appears that at the population level is not the case. The legalization of marijuana has not in any way decreased, reduced overdoses from opioids. But at the individual level, there is some evidence that shows that patients that have chronic pain that consume cannabis are able to use lower doses. So it's in that perspective that you can start to see cannabis. We have no data whatsoever, and it's an area that I think deserves scientific inquiry to address the issue. If someone have, for example, a cocaine use disorder, or they have an opioid use disorder, would the use of, if they use cannabis, do they actually have less of a severity? Do they end up consuming less drugs or not? We don't know. And I've been asking that question, and sort of actually I was engaging on trying to find out if there are databases out there through electronic health records, for example, that would allow us to see are there differences in outcome for people with an opioid use disorder that consume cannabis versus those that do not, to use the databases of electronic health records. But to my frustration, we don't necessarily enter in the electronic health records whether someone is using cannabis or not. So we're missing an opportunity to extract some information that would be valuable. I have never seen a researcher come up with a grant to say, I would like to study the effects of cannabis in basically in the symptomatology, in the craving, the withdrawal of people that have another substance use disorder, one of the ones that now we associate with high rates of mortality. Because now cocaine and methamphetamine, their mortality rates have gone up because they're frequently contaminated with fentanyl. So it is, again, the dialogue is shifting towards much more stringent interventions because the risks are so high.
Well, there's a lot to learn here. So as we come to the end, I want to ask you about two domains of research, since that is, as you noted at the outset, the primary function of any institute at NIH. So let's start with the clinical side. Again, we're not a clinical journal, but I think all of us would benefit from knowing what you would see as the clinical questions associated with substance use disorders that we don't have the answers to. You just mentioned a very specific example around cannabis and opioids, but I wonder more broadly, where do you think we would gain the most if we could focus our understanding on substance use?
Well, in terms of its therapeutics, I would say if we had a way of properly recording the pattern of drug use of patients in healthcare systems, we would be able to understand, for example, to what extent something that we don't actually even know, these drugs contributes to many of the medical diseases. Let's take an example, alcohol. Alcohol has been traditionally been associated with hepatic failure and cirrhosis. But it is until more recently that researchers have started to realize that it's associated with a wide variety of cancers. And research is also showing that it is associated with an increased risk for dementia. So I would love to see, for example, those cannabis, what are the relationship between cannabis and dementia in older people? We don't know it. And so you can say, okay, we are never going to be doing a randomized clinical trial, of course, where you're going to basically give cannabis to one group of people at the population and the other and follow them through. But we should have the data. So I think that if we were, and this will again needs to remove discriminatory policies that make it very hard sometimes to enter this information into an electronic health record. And it should not be. So again, it should be treated with the confidentiality that any medical condition deserves, but not with added obstacles, because it is at the peril of our ability to advance. And in that same line, and that's why, and the reason why you're seeing me responding in this way is I've started to see how extraordinarily powerful artificial intelligence can be if you have quality databases in terms of actually helping us identify personalized interventions and also predicting outcomes. In that respect, for example, we don't have it for substance use disorders, and that's why you see me navigating and saying this is something that we are missing an opportunity, and we're still failing. I mean, I was actually recently in the hospital, and I was teasing the doctor because the doctor did not ask me about whether I took drugs or not. So there are these flagrant omissions that we have. So that would be very valuable. Another aspect that would advance in the clinical world is what I said at the beginning. And again, this relates a lot in terms of policies and policies that relate to information in electronic health records that can be gathered, and policies that relates to reimbursement and the need to actually equate the payment system that will provide incentives for clinicians, whether it's a nurse practitioner, or physicians, to intervene in the screening and treatment of people with substance use disorders. That will make a big impact. And it will also then, at the same time, incentivize the schools for these professional healthcare providers to train them on the proper screening and treatment of people with substance use disorders. So I would highlight those that have actually linked with policy implications.
Well, I was going to ask a second question about policy interventions, but you beat me to it. So that's great that you use that as a second example. I think your comment about the data and the medical record is so interesting and important. There are obviously limits to what you can do just mining the data of an EHR, but there's a tremendous amount you can do to at least generate hypotheses that can be studied more deeply. And simply having data around substance use would make a big difference. Who knows what we might find? And that's would be a great starting point.
Yeah, let me jump at an example. It's actually because it's been so much in the news, and I find it so very fascinating. I mean, these glucagon-like peptide 1 receptor agonists that are used for diabetes and now for obesity, some of them. And basically the description by patients that they actually have reduced desire to take drugs or smoke. And going into the electronic health records, guess what? You can actually determine, are there differences in the pattern of drug use between those that have or not, or have, in terms of their diagnosis or their need of treatment. And out of these electronic health records, there is evidence starting to emerge that, yes, these glucagon-like peptides may be promising interventions for therapeutics. So now what are we doing? We're asking researchers to actually propose randomized clinical trials to evaluate them. So this is an example about where discovery can come. If you have the quality of data that you can flow through. And again, I think that we can improve significantly on the type of data that we have for substance use disorders.
Well, that's a great place to wrap up, and it will be an exciting area of discovery as we improve our computational power and hopefully our data collection on this.
But can I jump into one point, because I will feel really upset at myself if I don't pick it up, because I think that this is in terms of policy. A key policy that we need to change is the criminalization of people that take drugs. I mean, it's devastating at many, many levels. It makes the person more vulnerable. It increases the risk for dying from overdoses, and it affects their families. So, and it doesn't work, and it's costly. So whichever way you want it, it does not work. So policies that actually can lead to interventions for the person that is taking drugs that go into the healthcare model of addressing the situation as opposed to the punitive one have been shown. The evidence is out there. We don't need more evidence to show that they work. But yet we have these policies that are so terribly punitive.
Well, I am glad you squeezed that in before we close, because that is such a foundational element of how to proceed. Dr. Volkow, thank you so much for joining me today and spending an hour with us and our audience. It's been enlightening for me, and we've covered a tremendous amount of ground. And again, I want to just thank you for your contributions to the science and to the policy here. As we wrap up, I just want to let our audience know about some events that are coming up soon on Tuesday, December 5th, just next week, after the release of our December 2023 issue on lessons for global health from the COVID-19 pandemic. There's an event from 11 to 2 o'clock Eastern that's available to all. On December 19th, we have a journal club where Ashley Fox of SUNY Albany will talk about her paper, The COVID-19 Boosters. If the United States had matched Israel's speed and take-up, an estimated 29,000 lives would have been saved in the United States. Our Policy Spotlight event is open to all, but some of our events, including the Journal Club I just mentioned, are available only to insiders. Health Affairs Insider is it offers exclusive access to content that goes beyond the journal. And if you become an insider, you will gain access to these events. Please sign up on our website. We have many more events coming every month. You won't want to miss them through the balance of the year and into the new year. Go to healthaffairs.org/events to sign up for upcoming events and to get on our email list. Again, we always get asked, this event was recorded. We will post it within a few days, and we encourage you to share it with those who are unable to attend in person. Again, to our audience, thank you for submitting some questions, and mostly Dr. Volkow, to you. Thank you for joining me on our Policy Spotlight today.
And thank to you for inviting me.